Colleagues, management of CKD. Okay, we'll run through very fast because it's actually very simple. Okay, so number one, what I want to highlight is that you need to know the goals, your final points. What's your goal when you are managing a patient with CKD? Okay, the ultimate goal is mainly 5 things. Number one, you want to treat reversible causes of kidney dysfunction. Okay, number 2, you want to prevent or to slow down the progression of kidney disease. Okay, number 3, you want to treat the complications that come with chronic kidney disease. Number 4, you want to adjust the drug doses in keeping with your GFR. Okay, and finally, you want to identify and adequately prepare patients that need renal replacement therapy. Okay, those are your goals. Okay, now we're going to start off with the diet. What is the diet recommendations that this patient? Okay, remember to prevent your hypertension, okay, and especially also your fluid overload, your volume overload, you want to keep the diet low salt, okay, and to restrict fluid. Very important in patients with chronic kidney disease. Okay, then number 2, remember that you want to prevent your electrolyte imbalances, particularly potassium and phosphate and magnesium. So what you want to do is that you want to restrict your potassium. Okay, typically they say to 40 millimoles per day. Okay, you want to restrict phosphate. Okay, restriction. Okay, whether it's reducing it by dietary means, or you can use what we call phosphate binders. Okay, it can also be used, okay, typically to 1 gram per day. Okay, and also avoid extra dietary magnesium. Okay, for example, you can use antacids. Okay, they are useful to do that. Okay, very important because these patients are already deranged in these electrolytes. Okay, then another thing that you want to prevent is to prevent uremia. Remember, we have already highlighted the many complications of uremia. Okay, so you want to prevent uremia and potentially delay the decline of your glomerular filtration rate. And how are you going to do that? You are going to restrict your proteins. Okay, very important, but taking enough adequate caloric intake in order to limit that endogenous protein catabolism. Okay, so you want to make sure that at least your body is using something else for energy so that it doesn't break down protein, because the moment you break down protein, you are raising your urea level and uremia is imminent. Okay, so that's very important to know. Okay, so what about the medical treatment side of CKD? Okay, quickly, I'm going to highlight the role of the ACE inhibitor. Very important in CKD management, especially in our setting. Remember, ACE inhibitor, remember they dilate your efferent arteriole. Okay, if used very early, the goodness of this, if it's used very early, it reduces your risk to progress to end-stage renal disease. Okay, because as they slow your progression of proteinuria. Okay, which we'll come to in a bit. Okay, we'll come back to the ACE inhibitor, but I just wanted to highlight that. Now, remember, you want to control your cause, your comorbidities, your exacerbant. Okay, and what are those? Hypertension. Okay, remember, you want to control hypertension. We'll talk about it in a bit. Okay, diabetics mellitus. Remember, these two are the most common causes of chronic kidney disease. You want to have a proper glycemic control. Typically, we say HbA1c of less than 7% is usually your target. Okay, remember your cardiovascular risk factors. Stop smoking. Okay, very important. Okay, avoid your nephrotoxins such as your NSAID, your COX-SIBs, your IV contrast. Okay, especially with patients with GFR of less than 60. Okay, address all the reversible causes of AKI. Very important. If the patient is hypovolemic, control that hypovolemia. If it's a drug causing it, remove that drug. Very important. Okay, now back to the blood pressure. Okay, what is important in the management of blood pressure is that you need to know your target. If your patient is non-diabetic mellitus, okay, your target is typically 140/90 millimeters of mercury. Okay, however, the moment they have diabetes, your target should be way lower than that at 130/80. recent articles are always say it's more important to have a more intensive blood pressure lowering as opposed to not lowering aggressively. You need to be very aggressive in this way. You need to prevent progression to end-stage renal disease, especially if the patient has proteinuria. Remember, proteinuria is very nephrotoxic, okay, and you worsen the outcome in patients. So that's why you have to be very, very, very aggressive with your blood pressure monitoring. And what's the drug of choice? It will forever be ACE inhibitors, or of course, or ARBs, okay, because they are essentially the same thing, okay. ACE inhibitors have, as much as they can cause pre-renal failure, they are actually very useful in CKD because they are very renal protective, particularly if the patient has proteinuria, okay. If a patient has proteinuria with CKD, that's very dangerous because proteinuria is very nephrotoxic, okay. It will progress your patients to end-stage renal disease. So you want to give the lesser of the devils, which is ACE inhibitors, and it's very good to reduce that proteinuria. It is very good to lower your blood pressure to manage it. However, of course, because you are using an ACE inhibitor, the side effect will always be hyperkalemia. And of course, the moment you initiate or you start increasing the dose of an ACE inhibitor, we normally see a decline in your GFR very early, okay. So that's an expected side effect, okay. So that's very, very important that you make sure that you put in. I want to also say that loop, especially if your patient has fluid overload, okay, you can use loop diuretic, especially if your GFR is less than 25 mL per minute, okay. It will really help to strict control will limit your disease progression, okay. However, if you are struggling with a loop, you can add a thiazide, okay, so as a combo, okay, sort of to help you manage that, okay. Now, one thing I perhaps forgot to mention under the complications of presentation of CKD is that they get dyslipidemic, okay, and this is because, remember, there is reduction in the activity of your lipoprotein, whether it's your lipoprotein lipase or your hepatic triglyceride lipase, okay. This is due to this poor uptake of your triglyceride rich or other lipoproteins by the liver in your peripheral tissue, and thus it's natural that there will be increased circulating lipoproteins, okay. So they typically having very deranged lipid profile, okay, and typically we have a target of LDL less than 2 millimoles per liter, okay. You can convert that into units. However, we normally use statins, okay. Statins are very useful, or fibrates, okay. You can use statins. In our setting we have simvastatin, or you can use fibrates, which are much more expensive when they're in private, okay. That's very important to know, okay. Remember, these patients have hypocalcemia, they have hyperphosphatemia, and we have already highlighted all the problems that come with this, okay. Remember, thyroidism is increased, and that will essentially cause what you call uremic osteodystrophy, okay, which can come, these are your bone problems now, your osteoitis fibrosa, your osteomalacia, your adynamic bone disease, okay, all those, and you want to prevent that. You do not want hyperparathyroidism, okay. And what do you do that? You need to make sure that your patient have calcium supplements, okay, to treat the hypocalcemia, okay. Typically it's given between meals, and it binds, you can also give phosphate binders, okay, that will help reduce this, okay. Very important, long-term calcium and vitamin D prophylaxis. You see it all the time in our setting. We give calcium gluconate and vitamin D supplements, and this is to prevent this, okay. You do not want to run into patients with bone problem, okay. So that's very, very important to know, okay. Now, metabolic acidosis, whether acute or chronic, okay, in this case is chronic. Actually, all the evidence support that you can use if your patient is running into that. They have shown that it's actually very useful to use sodium bicarbonate, okay. So sodium bicarbonate can be used for metabolic acidosis, okay. Now remember, in CKD they get normocytic normochromic anemia because of erythropoietin deficiency, which is the primary thing, okay. There are other causes of that. However, the primary cause is erythropoietin, and so if it's erythropoietin deficiency, you give erythropoietin injections, okay. They are quite expensive. However, if your HB is less than 9, you have to give erythropoietin injection, and you have a target of anywhere between 9 to 10.5 grams per deciliter, okay. So that's very important to know, Okay, then remember we talked about clotting abnormalities. Remember uremia causes platelet aggregation problems, okay, and so these patients have bleeding tendencies, okay, so you can use desmopressin if patient have clinical bleeding or invasive procedures to act to reverse the platelet dysfunction, okay, so that's very useful to know. Dialysis, or let's call it rather renal replacement therapy, okay, remember we have discussed the indications of patients that will need it, so always keep out on the lookout for that. Things like uremic pericarditis, okay, the encephalopathy, okay, you will need to do renal replacement, okay, and just look out for that. Is very important in the medical management of patients, okay. Remember renal pruritus is one of the common complications of uremia, okay, very difficult to treat, okay, very difficult to treat, okay. However, you do see in better setting they use UV light, okay. People have used cholestyramine or these capsaicin creams, but they don't always work. It's very difficult to treat. Some people do dialysis actually to help with this if it's really bad. However, it's something that is very hard to treat, okay. Moving on to the surgical management, okay. Remember, the only real cure to chronic renal disease is a transplant, okay. Of course, that comes with its own problems that we'll discuss in other sessions. However, transplant remains the only viable cure to chronic kidney disease because it's very progressive, it's very progressive typically, okay. I wanted to mention something. Do look around. We've mentioned ACE inhibitors for the blood pressure, but do look around your SGLT2 inhibitors, your anti-diabetic drug. This drug has been used actually even in non-diabetic in some setting to prevent the progression of renal disease. So it's useful. It's an upcoming drug that we are starting to use, okay, so it's useful to read new articles on it, okay. Now, to end it off, always remember there are three main life-threatening complications of chronic kidney disease that you have to look out. Hyperkalemia, very dangerous, okay. Pulmonary edema, very dangerous, and as always, infection, okay. We do know how to correct hyperkalemia, we do know how to correct pulmonary edema, we have discussed that, but infections, I want to highlight some things, okay. It is recommended that every patient with chronic kidney disease gets annual vaccination against pneumococcal and influenza, okay. That's one. Okay. However, in patients with stage 4 and 5, okay, according to the KDIGO recommendations, okay, if the patient is in stage 4 or 5 and they're at high risk of progressing the disease, the CKD progressing, you also have to immunize them against hepatitis B. Okay, so that's very useful to know. Remember, patients really die of infections, so we want to prevent these infections to start with. Okay, and finally, remember when a patient with CKD is on the ward or you are following him up, you need to do this constant monitoring. Okay, and we normally do it through daily weights, okay, blood pressure, your urea and electrolytes, you watch out for infections, and finally your HB. Very important. I thank you.